Hello, good morning everyone. This instruction course is based on Pterygium, a very common disease to handle. The title is A to Z of Pterygium Management. I am Professor Dr. RAJIV Kumar GUPTA, Chief Instructor of this session. My co-instructor is Dr. Jahid Ali Siddiqui, Dr. Sunil Kumar, Dr. Vibhuti Bhushan, and Dr. Rashi Syam. As you all know, Pterygium is derived from the Greek word Pterygium, meaning simple wing. It is a slow-growing wing-shaped fibrovascular growth of bulbar conjunctiva which encroaches upon the cornea, usually from the nasal part of the limbus, the nasal pterygium within the interpupillar aperture. A fully developed pterygium contains three parts: head, that is the triangular apex of pterygium over the cornea, body, the main mass of the growth over the sclera, and the neck, junction of head and body at the limbus. Male are more commonly affected. The ratio of male-female is 2:1. Usually it occurs between 30 to 50 years of age, uncommon before 20 years. Mostly outdoor workers are the sufferer who are exposed to bright sunlight, dry and dusty environment. The exact etiopathogenesis of pterygium is still not well understood. However, various theories have been proposed regarding its etiology. Exposure to ultraviolet radiation is supposed to be a major risk factor. Ultraviolet exposure may induce hyperplasia in limbal cells. These altered cells invade the cornea and limbus, which move centripetally with them. This explains wing shape of the pterygium. Immunological factors is also involved. Cell-bound IgE irritant complexes initiates the release of inflammatory mediators from mast cell, which further lead to release of stimulatory factors and development of pterygium. The genetic factors involved are expression of hymentin. P53 mutation leads to decreased apoptosis and increased TGF-beta, which leads to increased growth. Hypoxia is also one of the major risk factors. Increase in non-perfusion area and attenuated vessel in nasal limbus during early stage of pterygium causes recruitment of progenitor cells. Infection with herpes simplex virus and human papilloma virus have been suspected also as risk factors. This is very important. Angiogenic growth factors. Increased level of pro-angiogenic factors may contribute to the progression of pterygium by means of angiogenesis. Coming to pathology, it is a degenerative condition of subconjunctival tissue which undergoes elastotic degeneration and proliferates as vascular growth tissue overlying the epithelium, which ultimately encroaches the cornea, destroying the corneal epithelium, stroma, and the Bowman's membrane. Histologically, it can be classified as angiomatous. Stroma contains a significant number of vascular cells, fibrous, where stroma is predominantly fibrous with a few scattered vascular elements, and the mix. One, stroma contains both vascular elements and thin bundle of collagen tissue. Clinically, it can be progressive or atrophic. Progressive is thick, fleshy, pink or reddish-looking vascular growth, which is progressive in nature. Atrophic is thin, papery, dry, pale-looking growth, which usually remains stationary. Location-wise, it can be nasal, it can be temporal or double pterygium. As far as stages of pterygium is concerned, stage 0 is lesion. When the lesion is posterior to limbus, stage 1 is lesion involves the limbus. Stage 2, lesion appears just on the limbus, and stage 3, lesion covers the area between limbus and pupillary margin. Stage 4 is the lesion is central to the pupillary margin. The prominent symptoms are cosmetic disfigurement, problem in fitting contact lens, reduced visual acuity. Other features may be redness, foreign body sensation, chronic irritation, dryness of eye, lacrimation, and restricted movement of the eye, resulting in diplopia. When a pterygium is examined, a small fleshy mass of conjunctiva usually drawn from medial canthus and which grows towards the limbus. It is a triangular encroachment of growth on the cornea. In front of the advancing age of pterygium, sometimes there is a line of infiltration indicating the progression of lesion. A pigment line called Stoker's line may be seen in corneal epithelium ahead of pterygium, which is due to deposition of iron pigment on the Bowman's membrane. It can be differentiated with pseudopterygium, which can be found anywhere around the limbus, which occurs mostly due to some inflammatory condition of the cornea and conjunctiva. It is fixed only at its apex to the cornea and not firmly and closely attached to the underlying structure. A probe can be passed beneath its neck, which differentiates it from true pterygium. Ocular sequence squamous surface neoplasia is the another disease which should be differentiated from pterygium. As far as complication is concerned, reduced visual acuity due to induced astigmatism or encroachment of pupillary area of cornea, disruption of precorneal tear film, diplopia due to restricted eye movement may be inflamed intermittently. So when we have to do treatment for pterygium, it should be either for cosmetic purpose, when the vision is threatened, induced astigmatism, contact lens intolerance, and prior to cataract surgery and before planning for refractive surgery. Treatment is essentially surgical. Medical management is in the form of prescribing tear substitute or mild corticosteroid or NSAIDs, which can be given for symptomatic relief. The main important point is to prevention from the bright sunlight. We should protect bright sunlight from either from sunglass or wearing cap or hat or educating the people. Surgical management is essentially bare sclera technique, which is the most common, but due to high recurrence rate, which is about 30 to 91%, it is not preferred. Recurrence with bare sclera technique is very common. A number of factors have been reported for the recurrence of primary pterygium. One of the factors responsible for recurrence is post-operative conjunctival inflammation and fibrovascular growth. It has been reported that persistent conjunctival inflammation around the surgical site after the surgery is present in about 15% cases of conjunctival autograft. Increased level of growth factor, especially vascular endothelial growth factor, which is known to be produced in response to several stimuli including ultraviolet radiation. So what should we adopt strategy for prevention of recurrence of pterygium? Recurrent pterygium is more difficult to manage due to thinning of underlying cornea and extensive scarring. Considering the different factors responsible for recurrence, various treatment modules have been adopted, which can be change in surgical technique or use of adjuvant therapy. Adjuvant therapy either in the form of beta radiation, argon laser, chemotherapy, applying thiotepa, doxorubicon, steroids, mitomycin C, 5-fluorouracil, cyclosporin, alcohol, anti-VEGF, and doxycycline. And the adjuvant surgery may be in the form of lamellar keratoplasty, amniotic membrane transplantation, conjunctival flap, conjunctival autograft, conjunctival rotation graft, perfect cultivated conjunctival transplantation. This instruction course on pterygium presents certain guidelines and highlight particular treatment strategy for the prevention of pterygium recurrence. It is designed to be relevant, scientific, and practical. With this, I invite Dr. Zahid Ali Siddiqui, my co-instructor, to present his presentation. Thank you.
Good morning. I'll be talking about the adjunctive therapy in the pterygium management, as Dr. RAJIV GUPTA was talking about the commonly used procedure. Bare sclera leads the lot of recurrences in the past. This was the most common technique in the previous decades, and many smaller places still this is prevalent even nowadays. And it has a recurrence rate of kind of 30 to 90%, and that recurrence rate led to the use of lot of adjuvant therapy to prevent the recurrence post-operatively. And it varies from the radiotherapy to laser, use of lasers, many antimetabolites and other medication to prevent the recurrence. We'll go through the most commonly used adjuvant therapy presently or in the past. The first, I'd like to talk about the beta irradiation. It was used in the previous decades, and it was mode of action was it inhibits the proliferation of fibroblast, either used singularly or in a combination with the other medication. And the mode of application was either pre-operatively or intraoperatively, or sometime even the first 24 hours, the post-operative period. A single dose of 2,500 to 3,500 rad units. And it has a recurrent, very varied published rate of recurrence, varying from no recurrence to up to even 60% of the in the studies. But it is associated with a lot of complication and nuances. Complication was like conjunctival inflammation, corneal melting, scleritis, cataract, uveitis. And this was unpopular because of the potential rate of the complication, higher cost, and there was a special arrangement required to use radiation in a localized area in our operation theatres. Even argon laser treatment was used, but it was not as common as a beta radiation was used. We could find a study where this group has used argon laser treatment in the treatment of Pterygium. They divided in 3 groups. First group they treated only, used the Bayer's color technique, excision of Pterygium with the cauterization. And in the next group, after excision, they applied argon laser treatment. And in third group, they used only argon laser treatment. And they concluded that in the argon laser treatment group, there was no Pterygium grew more than 1 millimeter in next 2 years. But that is not, there are not many studies found. Another medication used for adjunctive therapy was a steroid, intralesional steroid, but this is associated with the high elevation of IOP, glaucoma and cataract formation in the patients. So it discontinued, but still some people use low tepridinol itibenate because of its milder form, because it penetrates cell membrane very rapidly and causes, it has a less potential of IOP rise and not causes much of cataract also. It is used in a ointment form. A one-time application in night is used, but we couldn't find any significant clinical trial on this medication. Cyclosporine is an immunosuppressive drug used in the treatment of Pterygium in the past. It prevents the synthesis and secretion of interleukin and other inflammatory agents. It blocks the anti-angiogenic factors. Method of application was in the topical eye drop. Most commonly used concentration was 0.05% or 0.1% drops for prevention of recurrence in the Pterygium surgery. Other mode was the cryotherapy, where liquid nitrogen is used for the cryotherapy of the Pterygium. And because this is very cold, it causes the destruction of a small caliber vasculature, leading to the intracellular crystallization of and leading to cell rupture, causes denaturation of protein lipid complex, and causes vascular stasis and leading to the progression of Pterygium growth. In this study, they have used contact time around 1 to 2 seconds of application of cryo, and they found there is only 0.5% of recurrence after 6 months post-operatively. And they concluded that it is quite safe, convenient, and the surgical time is very less. why there is a recurrence? Recurrence happens because of there is an imbalance between angiogenic stimulator and inhibitor balance. Vascular endothelial growth factor is one of the angiogenic stimulator. So, once we develop anti-VEGF compound available for our retina colleagues, people started using it for the prevention in the recurrence of pterygium also. Avastin was the most commonly used because it was available in the multi-dose vial, and almost every center has got its availability. So mode of application was either used single therapy or in combination with the other adjuvant treatment, and it was used intralesionally preoperatively also, and as perioperatively also as a subconjunctival injection, and it has been tried also as a topical drop postoperatively after primary pterygium surgery. This RAJIV group has studied in decreasing the pterygium size as an intralesional injection of Avastin. They studied 17 patients, 14 were a primary pterygium and 3 were the recurrent pterygium. The dose was 2.5 mg in 0.1 ml, and they concluded that the intralesional Avastin injection was fairly effective in reducing the size, but that was not very clinically significant. And in this group they have used the post-operative topical Avastin drops, and they divided 30 patients in each group. The first group was given post-operatively a standard antibiotic plus steroid combination for 2 weeks, and in another group they added Avastin drops over the antibiotic and steroid drops, and concluded that the post-operative short-term therapy of Avastin doesn't statistically decrease the rate of recurrence, although it reduces the new vascularization significantly. And in the other group where they tried the recurrent in the pterygium surgery, where there is an autograph was done, and they studied 88 patients. In the one group, they used the antibiotic plus steroid, and in the second group, additional Avastin drop was used along with the limbal conjunctival autograft transplantation. And their conclusion was that topical bevacizumab seems to have no additional role in preventing the recurrence of pterygium over the limbal conjunctival autograft transplantation. Now comes the antimetabolites. There are two very commonly used, the 5-fluorouracil and mitomycin C. Their cytotoxic action on the fibroblast leads to the use of the adjunctive therapy in the pterygium surgery to prevent the recurrence. Either it can be used as a single adjuvant or in a combination. It was used as an infiltration during surgery, in the subconjunctival infiltration, or postoperatively as a topical drops. This has a study where they compare the 5-FU as a topical and intralesional injection. Both arms has 50-50 patients. And they concluded that both has the similar result, comparative result, but intralesional injection has very few side effects and it's very convenient to use. Mitomycin C is a cytotoxic to the fibroblast and vascular endothelial cell. It can be used as a subpterygial injection or as a perioperatively by a sponge, or it can be used as a topical drop in the post-operative period also. Mitomycin has lot of complications, side effects, and most of the people have seen in their practice. It causes irreversible cell damage, scleral and corneal melting, dry eye, toxic keratoconjunctivitis, uveitis, secondary glaucoma. It should be avoided in the dry eye syndrome, ocular surface disorder, neuropathic diseases. So, this Thiago Gonzalez has collected all the data available in the PubMed in English literature over the pterygium, where mitomycin was used in adjunctive therapy. And they found 25 trial where mitomycin C was used pre-operative period as a subconjunctival injection. So that increases the exposure time of the mitomycin to the lesion, and they found there is a very less recurrence rate, and there was no serious complication in this group. And there are two doses mostly used, either it is 0.15 milligram per ml or 0.4 milligram per ml dose. This higher dose has a higher rate of complications. And per operative use of mitomycin C, there are varying concentration was used, varying from the 0.002% to 0.4%, and duration of application was 3 to 5 minutes. All MMC concentration were able to reduce recurrence rate post-operatively significantly when compared to the bare sclera method. The recurrence rate reported was 7 to 22%. A most common dose used was 0.02% for 3-minute application over the conjunctiva, followed by copious irrigation of the area. And complications were higher in the higher concentration used and lower in the lower concentration used. And this is about mitomycin C used after surgery in the post-operative period in the form of drops. And they could find 12 trials over that. And there are two concentrations were used, 0.02% drop twice a day or 0.04 drop thrice a day for 1 week. The lower strength has also reduced the recurrence rate, but it has the less complication post-operatively. But in the higher concentration, the complication rate was 5 to 19%. So they concluded the increased exposure, that is dose and duration of mitomycin C, is associated with the lower recurrence rate of the pterygium, but it is associated with the higher rate of the complication. So you have to find a balance of dose and duration for the recurrence and occurrence of complication. This study has compared between the bare sclera and two metabolites we have discussed, mitomycin C and 5-fluorouracil. They found out that the mitomycin C and 5-fluorouracil significantly reduce the recurrence, but mitomycin is better than 5-fluorouracil, and 5-fluorouracil was better than bare sclera. But 5-fluorouracil was not statistically significant in reducing the recurrence. And this is a meta-analysis on anti-fibrotic, anti-VEGF and radiotherapy used in the pterygium surgery. They have found around 34 randomized RCT, where around 2,500 patients were either given anti-fibrotic or anti-VEGF or radiotherapy. And the technique of surgical technique were either bare sclera technique or excision with the tissue grafting. And the anti-fibrotic agent, 5-FU and mitomycin C are used, anti-VEGF was Avastin, and beta radiation was used in the radiotherapy group. And the result of this meta-analysis was that mitomycin C, beta radiation and Avastin, but not 5-FU, were significantly more effective than the placebo in reducing the recurrence following the pterygium excision with or without tissue grafting. Mitomycin C has the highest probability of having the most efficacy in reducing the recurrence among all, although Avastin was ranked higher than beta radiation, but the difference was not statistically significant. The other adjuvant surgery are now you are using very frequently for the pterygium surgery, but my esteemed colleagues will discuss about this thing, so I will keep it here. So my take-home message is that a direct comparison among the study remains difficult because most of the techniques are not used nowadays, and so excision alone without adjuvant treatment is now no longer acceptable. Bare sclera is not a method of treatment now. You have to use either surgical adjuvant therapy or medical. It is accepted that the various adjuvant therapy and their combination have significantly improved the treatment outcome in the term of recurrence, cosmesis and patient satisfaction. Conjunctival autograft is now preferred because of long-term safety and concern. Thank you.
Thank you, Dr. Jayed. Now I invite my other co-instructor, Dr. Sunil Kumar, who will talk on conjunctival autografting in primary pterygium and technique of graft fixation. Over to Dr. Sunil.
Thank you, sir. So, good morning, everyone. So, I will be presenting on the conjunctival autografting in primary pterygium and what are the different techniques of the fixation of the graft. So, I have no any financial interest in any of these products or technique mentioned in my presentations. So, as of today, the pterygium excision with conjunctival autograft is the standard of the care in the management of the primary pterygium and also in the recurrent pterygium also. So, all the indication of surgery in primary pterygium, this is already discussed, just repetition. The surgery indicated in case of the symptomatic patient, if the patient presents with the recurrent irritation, redness or watering, or if there is any visual disturbances, it may be due to pterygium enclosing the visual axis or because of the irregular stigmatisms. And cosmetic purpose is the most common indication for the surgery, and there can be the therapeutic indication also if it restricts the wearing the contact lenses, or if the patient is planning for the refractive corneal surgery, or before the cataract surgery also. So coming to the pterygium excisions. So removal of the pterygium involves basically the surgical excision of the head, neck and the body of the pterygiums. And the body and the base of the pterygium are dissected with the conjunctival scissors, while the head and neck of the pterygium that has invaded the cornea is often removed with a surgical blade. And an attempt is made to identify the plane of dissection which facilitates the removal of the pterygium while keeping the underlying corneal surface smooth. And remnant stromal attachment may be smoothed out with the help of the blade or diamond burrs. So bare scleral excision, when if no additional measures are performed, we call it the bare scleral excision, but the recurrence rate is very high. It may be up to 80 to 90%. So as such, bare scleral excision is no longer recommended nowadays. So we have to do some adjunctive treatment to prevent the pterygium recurrence. So all the adjunctive therapy has been discussed by the last speakers. So the surgical methods basically include the conjunctival autograft. It could be the limbal and limbal conjunctival transplants. It could be the conjunctival sliding flaps, or even the conjunctival rotation autograft, amniotic membrane transplant, cultivated conjunctival transplant, or even the lamellar keratoplasty sometimes required. So the conjunctival autograft is the most common procedure performed, and this is the procedure of choice nowadays. Here the free conjunctival graft is harvested from the superior or supratemporal bulbar conjunctiva and is sutured in place over the bare scleral defect. So this is the case of the primary pterygium, and we have harvested the conjunctival graft from the superior bulbar conjunctiva and it is secured in place with the help of the sutures. So why conjunctival autograft? Because it has the lowest rate of the recurrence. It can be as low as 2%. It has minimal side effect and complication. It is also very cost effective, and it has better post-operative comfort as well as the cosmesis. So conjunctival, what could be the ideal conjunctival autograft? It should be as thin as possible. It should be completely devoid of the Tenon's capsule. We should have dissected very carefully to avoid the buttonholing, and the size and shape of this conjunctival autograft should be same as the bare scleral defect. And also the orientation of this conjunctival autograft is very important. The limbal side of the graft should be toward the limbal side of the bare scleral defects, and the epithelial side of the graft should be toward the surface and the stromal side toward the bare scleral defects. So we have to measure the area of dissections. So we have to pull the eye downwards, use the Jensen violet or any marker pen to mark the area, and also we have to mark the central area to help the orientation. We just inject the subconjunctival 2% xylocaine with adrenaline with 26 gauge needles to separate the conjunctiva from the Tenon's capsule, and we have to carefully dissect the conjunctiva. and we have to make the graft as thin as possible and avoid the button links. So this is just to show the marking for the harvesting of the conjunctival autograft. We have to measure the length as well as the breadth of the defect, and also the central mark should be done to avoid the orientation, whether epithelial side is up or down. So alignment of the graft we have already discussed. We have to slide this conjunctival graft on the cornea and then onto the scleral bed with care that limbal side of the graft remains towards the limbal side, and also that epithelial side remains towards the surface. So there are different techniques of the conjunctival autograft fixation. It could be the suturing, which is most commonly generally used, with 10-0 nylon, or even the Vicryl can be used, and the use of the fibrin glue. And nowadays we use the autologous blood. So suturing of the autograft. We first secure all the four corners with the scleral bite, and we have to avoid the medial rectus to minimize the bleedings, and close the nasal conjunctiva to the conjunctival of the graft, and here no scleral bite is taken, and close edge to edge separately as well as inferiorly. But we have to care that there should not be any exposed Tenon's capsule, otherwise granuloma formation can take place, and generally we avoid the running sutures also. And after this we apply the bandage contiguance. So this is just very small video showing the conjunctival autograft with suturing. Yeah. So after the pterygium dissection, we have to measure the size of the bare scleral defect. And we carefully dissect this conjunctival autograft. We have to make it very thin. And this is the securing the graft with the help of 10-0 nylon sutures. And this is the very small videos with the fixing the graft with the fibrin glue. Sorry. So here we have to measure the size of the graft and careful dissection of this conjunctival graft. And here we are applying the fibrin glue. One component is applied on the scleral bed and another component on the back surface of the graft. And we have to just slide this graft, and we have to spread it evenly, and we have to apply just pressure over this. So this is just first of photograph. We can see the conjunctival graft, which is firmly attached to the underlying sclera using the fibrin glue in this first photograph. And this is the post-op after 1 year's follow-up. And below this is the fixation with the 10-0 nylon suture, and this is the post-op picture 1 year with very good cosmesis. We can also use the autologous blood. Here the no glue or suture is required. Patient's own blood at the bare sclera site is used to secure the graft. Here we have to take slightly larger size graft, at least 0.75 to 0.21 millimeter oversize, to prevent any gap between the edges. And here the pressure is applied with any blood instrument to fix the graft, at least for the 5 to 7 minutes. And the bandage is applied for at least 24 hours. But there can be also the complication with this conjunctival autograft also, like recurrence, inflammation, infections, bleeding, sometimes Dellen formation occurs, or the granuloma formation. These are some of the pictures showing the post-operative complications like the graft edema and inflammation. They can be the graft necrosis also in some cases. They can be the Dellen formations, or the recurrence can also occur. So to conclude, the pterygium excision with this conjunctival autograft is the procedure of the choice for primary as well as the recurrent pterygiums. And ideally the graft should be very thin and devoid of any tenons capsule. It should be of the same size and shape as of the scleral defect and should be aligned properly. And also the graft should be well secured in the scleral bed, either with the sutures or fibrin glue or the autologous blood with edge-to-edge appositions. So thank you very much.
Thank you, Dr. Sunil. Now I invite Dr. Vibhuti will talk on perfect slit, mini slit, permanent slit, and he will also tell that how zero recurrence can be achieved. Over to Dr. Vibhuti.
Good morning, everybody. First of all, I must thank AIOC for giving us this opportunity and our Chief Instructor, Professor RAJIV Gupta, for giving me this opportunity to talk on this very common problem that all of us face in our day-to-day practice. And we have evolved from bare sclera to the gold standard technique of conjunctival autograft that my colleague Dr. Sunil and Dr. Zahid discussed. But still we have some recurrences. Even the gold standard technique, different studies have shown that there is a recurrence rate of about between 2 to 10%. So can zero recurrence be really achieved? So that is what I am going to talk about, and let us see by the end of this talk where we reach. Excuse me, it's not moving. Why do we need zero recurrence? Because any recurrent pterygia, it has a more aggressive clinical course, it damages more, it is more difficult to treat than the primary pterygia, it can lead to restrictive strabismus also, and that is why it is always better to prevent the recurrence. So to remove the pterygium is the best opportunity. The first opportunity to remove the pterygium is the best opportunity to avoid all these complications and frequent visit of the patient. As it was discussed, the primary pterygium is basically an elastotic degeneration, but the recurrent pterygium is predominantly fibrotic. And the causes of recurrence are surgical trauma, which we create, we disturb the tenons and it reacts and grows again. There is a fibroblastic proliferation. It is not UV mediated, as the theory has proved that the primary pterygium, the UV plays a very important role, very major role in the development of primary pterygium. Recurrence rate, bare sclera, it touches the roof actually, 24 to 89% different studies, conjunctival autograft 2 to 12%. Amniotic membrane graft has also been used instead of conjunctival autograft, and that was again the reported percentage is 4 to 40% in different studies. There is a technique, perfect technique, I will be talking about it, which has significantly reduced the recurrence rate to around 1.5%. So this gold standard technique, excision with ocular surface reconstruction with conjunctival autografts with or without amniotic membrane graft. It is a very safe procedure with low recurrence rates and excellent cosmetic results that Dr. Sunil discussed. The causes of recurrence in conjunctival autograft, which is the gold standard technique, is insufficient graft size. If the graft is thick, graft retraction or inversion happens. If there is inadequate tenons resection, if there is incomplete control of the post-op inflammation, and to start with, we had a very higher morphologic grade, very fleshy and very vascular pterygium. So this is the technique. Dr. Lawrence Hurst of Australia is the father of this technique. He developed this technique some 20 years back, almost more than 20 years back, which is called the perfect technique. And the name actually justifies that. Perfect stands for pterygium extended removal followed by extended conjunctival transplant. This technique was pioneered by Australian ophthalmologist Lawrence Hirst. Over the last more than 20 years, Professor Hirst has developed a surgical procedure for the removal of pterygium, which is a marked modification of the existing gold standard technique of CAG, and it has resulted in the best results reported in the world's scientific literature. It has got three components. The first component is the incision of pterygium head and then stripping of the head from the cornea. And then he developed a technique of extensive tenons removal. This tenon is removed almost from the medial, if it's a nasal pterygium, from the medial edge of the superior rectus to the medial edge of the inferior rectus. You have to actually dissect quite a large area of tenons, almost to the superior and inferior rectus muscle, and over the medial rectus muscle extending back up to the caruncle. So this is the extended dissection of the tenons. And adequate tenon and conjunctival removal will result in visible bare sclera above and below the medial rectus muscle. We have to hook the medial rectus muscle. This technique, many times pterygium surgery is done under subconjunctival infiltration of the anesthetic agent, but this technique has, it needs a peripalpal block. We need to hook the medial rectus, pull the eye, and then we will be able to dissect the area, dissect the tenon from the area that we want to remove. So this is a diagrammatic representation. You can see the dissection is from here to here, right up to the caruncle, and the medial edge of the superior rectus to the medial edge of the inferior rectus. This whole area, the tenons and conjunctiva, needs to be removed. Second component is obtaining a very large and thin conjunctival graft, because we have removed exposed a very large area, so it needs to be replaced with a very large conjunctival graft, and then again we have to rotate the eyeball down if we are removing, if we are harvesting the conjunctiva from the superior bulbar conjunctiva. A successful autograft should be virtually transparent without any tenons layer carried over with the graft. This helps to ensure that the donor side will heal with minimal to no scarring, and a repeat graft can be harvested after a few months from the same area. Actually, this is very important because we are removing a very large piece of conjunctiva to fill that gap. We will not have sufficient conjunctiva to pull back and again fix it to the limbus, because a large area of conjunctiva is removed. So we have to be extremely careful in removing that so that it reepithelializes on its own without pulling the conjunctiva and fixing it again to the limbus. And again, after a few months, it will reepithelialize, and the same area can be used to harvest another graft if needed. The third component is reconstruction of the pterygium site by its large conjunctival autograft to obtain optimal cosmetic result. Now, there are some cons of this technique. The first is it's a very long procedure. It takes around 1 hour time. It needs a peribulbar anesthesia. It requires a surgical assistant. It's difficult to do it alone. And it has a structured learning curve, how much tenons to remove, and harvesting a very large conjunctival graft. It does need some practice, and it should be attempted in primary pterygia first, because recurrent pterygia are difficult and we don't know how far we have to dissect. These are some of the pictures of Dr. Hirst, who had done this. This was a primary pterygia case. This is again a few pictures. This was a primary pterygia. This was a recurrent pterygia, and this patient had surgery almost 10 times, and this was done with the perfect technique, and this is the outcome that we can see. A number of studies by Lawrence Hirst has been published. In 2008, he published in primary pterygia about 250 patients which were followed by for more than 1 year, and there was zero recurrence with this technique in 2008. Then again in 2009 he published a report with 111 patients with recurrent pterygia, and they were also followed up for more than 1 year, and again in his series there was not a single recurrence, and there was excellent cosmesis. In 2012 he had a huge series of 1000 patients, of which the primary patients with primary pterygia were 806 and recurrent pterygia were 194. They were followed up for more than 1 year, and the recurrence rate was found to be 0.1%. And in 2020 again he published a report of 1000 patients with primary as well as recurrent pterygia who were followed up for 10 years. And again he reported zero recurrence rate with excellent cosmesis. So can we consider the perfect technique as the new gold standard, which was previously the normal conjunctival autograft? CAG is still considered to be the gold standard, but considering the less number of recurrence rates, less recurrence, virtually nil, can we consider perfect the gold standard? Because it provides the long term and stable results for a primary as well as in recurrent pterygium. There is zero recurrence rate and excellent cosmetic appearance of the eye and no serious complications. The cosmetic outcomes now after pterygium surgeries have become more sensitive measure to success than recurrence rate alone. If we control the recurrence, then definitely the cosmetic value of this surgery increases manifold. Then the next move came, not next move, simultaneously these concepts were being propagated, that the reason of pterygium is there is some problem with the limbal stem cells. It has been proposed that limbal stem cell disease is the inciting event in pterygium formation, and limbal stem cell represent the barrier to potential conjunctivalization of the cornea, and if they are damaged, fibrovascular proliferation onto the cornea as is seen in pterygia becomes possible. So we have to take care of the limbal stem cells. Mini slit is the minimal simple limbal epithelial transplant. It's a technique that was first described by Dr. Sangwan in 2012. The mini slit is a newer procedure which requires the harvesting of less limbal stem cell tissue and theoretically reduces the risk of iatrogenic stem cell disease. If we remove a very large piece of stem cell, then we leave that area vulnerable, and the cornea can develop some problem because of lack of stem cell in that area from where we are harvesting. But in this mini slit, we just have to remove 1 clock hour of stem cells from the limbus, and it makes it possible to harvest the limbal stem cell from the same eye. The steps of the mini slit technique are the resection of pterygium normally as we do, and excess of tenons with conventional techniques leaving bare sclera, and then we don't use conjunctival autograft, we use amniotic membrane only. We place the amniotic membrane and with the help of fibrin glue. Then resection of epithelial limbal stem cell graft of only 2 into 2 millimeters from the area that is healthy. And what we do is we slice the epithelial limbal strip into 4 to 10 pieces. That small 1 clock area limbal stem cell is sliced into different smaller pieces, and then we align those pieces around the limbus over the amniotic membrane that is covering the exposed sclera, the bare sclera, with the help of fibrin glue. Some people have put a second layer of amniotic amniotic membrane graft over those small pieces of limbal stem cells, and some have fixed the stem cell pieces also with the help of fibrin glue on the limbus, and you finish the surgery with the placement of the soft contact lens, so that for initial few days the stem cell pieces, they remain in place. Now this is a series of pictures. Here you can see the pterygium is there. Here pterygium has been stripped and you can see the bare sclera. In the third picture in C, you can see the amniotic membrane has been placed. Now in this picture D, you can see the area from where a small strip of limbal stem cell has been harvested. It is this, the only 1 clock hour area is used, and these are the small strips, small pieces. They have been split. This small area has been split into different small pieces of limbal cell, and they are placed here. They are fixed with fibrin glue, or over them again an amniotic membrane graft can be put, and finally a contact lens, a bandage contact lens is put. Now these small pieces, they grow and they fill that area, the whole area. So even if we place them separately, there is a gap in between the limbal stem cells, they grow and they fill that area, and the amniotic membrane, they help amniotic membrane that is below that, it helps in their growth. A few studies about mini slit technique. The simple limbal epithelial transplantation, a novel surgical technique for the treatment of unilateral limbal stem cell deficiency, was published in 2012 in British Journal of Ophthalmology. Here the bandage contact lens was placed over the stem cells as described by Sangwan's initial technique. A minor ipsilateral simple limbal epithelial transplantation for pterygium treatment. Again, it was published in 2015. But it looked only at the primary pterygium excision, and a second layer of amniotic membrane was used on top of the stem cells. Then a series of 4 cases of recurrent pterygia was reported in 2018. Excuse me. Then mini slit versus conjunctival autograft fixation with fibrin glue after pterygium excision. A randomized controlled trial was done. In India, in AFMC it was done. Dr. Alok Sati was the main brain behind that. And they, they concluded that the study group exhibited a positive trend of less recurrence with reduced postoperative symptoms and other complications. More similar studies are required in future to validate the results. Not many randomized controlled trials have been done. So now we had a perfect technique, and then in perfect technique we had to use a very large conjunctival graft. In mini slit we avoided using the conjunctival graft. We used amniotic membrane and used stem cells to cover that area. What if we combine both the techniques and take advantage of both the techniques? The complete and extensive removal of tenon, and we don't use the conjunctival autograft, we preserve conjunctiva and use anti-inflammatory benefits of the amniotic membrane graft, and replacement of pathologic stem cells with normal cells. So in this technique we are combining half of the perfect technique. We are resecting the tenons and conjunctiva from the pterygium, but we are not harvesting conjunctiva, we are not putting a conjunctival autograft, but we are using amniotic membrane graft and stem cells. So this was the, again Dr. Alok Sati, he did this, developed this technique, and as we say that necessity is the mother of invention, he had a patient who had undergone multiple pterygium surgeries. He had that patient had recurrence, so there was hardly any conjunctiva left, and that patient had a primary open angle glaucoma also. And when he saw that patient, initially he thought he will do perfect technique, because there was 2-3 surgeries, previous surgeries were already done. So he decided to do a perfect technique, but on examination he found that there is no conjunctiva left to harvest for such a major technique. So then he tried to combine both the techniques. He thought of using amniotic membrane graft instead of conjunctiva and limbal stem cells. So that is how this technique developed, and it is called permi-slit. Pterygium extended removal followed by minor ipsilateral simple limbal epithelial transplantation. In this case, we preserve the conjunctiva, which is a major advantage, especially in patients with double-headed pterygium, where if we are doing both the pterygia at the same sitting, it is difficult to get to harvest that much of conjunctiva from the same eye. In patients with glaucoma, where we want to preserve the conjunctiva for any future interventions that might that the patient might need, and if there is a history of previous surgeries where conjunctiva is already scarred or not healthy. So these are the ideal candidates where we can go for this permi-slit. We dissect everything. We dissect a large area of tenons, as was discussed in perfect technique. Conjunctiva also from that area. Then we use amniotic membrane graft, fix it there with fibrin glue, and use limbal stem cells. So till now he has reported 6 cases. Dr. Alok Sati has reported 6 cases of recurrent pterygium. He has done this technique in all the recurrent cases, and he found no recurrence, no symblepharon, no movement restriction, very good cosmesis, and the most important thing was that the conjunctiva was also preserved. So till now we have reached here. No one knows what is there in store in future, how we can do it, but with the help, with the perfect technique and mini-slit technique, definitely the recurrences can be reduced. And I strongly feel that now the conjunctival autograft, which was considered to be the gold standard, now the perfect technique or mini-slit technique can be taken as the gold standard, and other studies should be compared with these techniques. Thank you very much for your patience here.
Thank you, Dr. Vibhuti, for an excellent presentation. Now I invite Dr. Rasi Shyam, who will talk on conquering pterygium in unusual situation. Over to Dr. Rasi.
Good morning, everyone. Primarily at the outset, I would like to say that in trying to teach, we also learn. I'm a glaucoma specialist, and now I'm going to present one of the slightly atypical topics of pterygium. So what are unusual situations to identify such a common problem as pterygium? We have to know that pterygiums with cystic degeneration, pigmentary changes, those involving pupil double pterygiums, recurrent pterygiums, pterygium where we have to do a cataract surgery also, patients of glaucoma, eyes where the cornea and conjunctiva are scarred from previous ocular surgeries, post-LASIK patients and PK patients. These are a few unusual situations. So let us cut to the chase. Cystic degeneration in pterygium, as high as 37.5% of conjunctival cysts are seen on the head of the pterygium. Here, studies say that cyst rupture should be avoided, and pterygium excision is done as usual with conjunctival limbal autograft. Recurrence rate is much higher if the cyst ruptures during surgery. Pigmentary changes in pterygium is also very common, and it gives poor cosmesis, so the patient is very bothered about how it will be after the pterygium has been excised. Surgery is again as usual. However, there are conditions where we need to differentiate the pigmentary degeneration from a atypical melanosis or a melanoma. Atypical melanosis becomes pre-malignant, and melanoma, of course, is quite a serious condition. So here, the differentiating factors are there is irregular surface of the pterygium, irregular pigmentation, there is significant stromal invasion, typical parts of the pterygium is not identifiable like a head, neck and body, and surgery is best done by a corneal surgeon who is experienced in this. Wide local excision with corneal epitheliectomy needs to be done by a no-touch technique. Cryotherapy and antimitotic agents may have to be used. Histopathology is mandatory, and long-term follow-up care is also mandatory with an ocular oncologist. Now, acquired melanosis sometimes occurs in the graft itself. So this is very challenging for the operating surgeon, because you do something primarily for cosmetics. You do a good graft, there is no recurrence. But what happens is the graft itself becomes pigmented and gives poor cosmesis. So if there is any suspicion of a different kind of problem, then please repeat the surgery like we do in any other repeat pterygium, recurrent pterygiums, with a 4.4 to 5 edge clear excision. Or sometimes topical mitomycin C is used in 2 to 3 cycles. So we can dilute the mitomycin C like we do for local application in glaucoma surgery. It can be given 4 times a day for a week, and then you stop it for 2 to 3 weeks and see how the patient is. And if it is all right, you can give the same schedule for 2 to 3 cycles more. Now, there are pterygiums that encroach the pupil, and this causes certain different kind of surgical challenges. Central corneal thickness is hardly 550 micron. It is the thinnest area of the cornea. So minimal meticulous dissection of the cornea should be done. Sharp tipped instrument near the center should be absolutely avoided. Stripping is much safer in this kind of eye. Antimitotic agents should be avoided. And the complications are worsening of the astigmatism. Sometimes there is corneal ectasia, sometimes even perforation. So if there is thinning of the cornea while surgery is being done, it is good to give a tectonic support with an AMG if available. And if everything else fails, then the cornea surgeon can take them up for keratoplasty. Now, double pterygiums are also quite common, especially in the western part of our country. And here the challenges become that you need a large graft, and if you take a large graft from the same eye, then you are almost involving 180 degree of the conjunctival bulbar graft available near the limbus. So there are different techniques for this. A split graft may be used. Now, split graft may be taken superiorly only, and then the graft can be split horizontally or vertically. It has been seen that the results in both are the same. So I want to emphasize that if we take a small limbal base and then we do a horizontal split, that way we are involving less of the limbus itself. So instead of doing a very large graft and giving it a vertical split, we can do a horizontal split also, and I personally feel that is better. We can use the conjunctiva of the pterygia itself also. That is also another technique that is being used by the corneal surgeons now. We know that pterygiums are subconjunctival elastotic degenerations. So if there is a relatively healthy conjunctiva available, excise the pterygium, do a good dissection of the conjunctiva above the pterygium, preserve it, and rotate it and use the same conjunctiva over the excised area. We can harvest the graft from the superior or the inferior part also, but inferior conjunctiva is not so easy to dissect, and again you are involving 180 degrees of the limbus, so there is a risk of stem cell deficiency. Now, in one of the talks I saw that bare sclera size, usually we try to keep the graft as large as the bare sclera is after primary excision. However, if that is not possible, we can reduce the size of the bed itself. So we can put sutures to reduce the bed size and then take a smaller graft to cover it. So this is a double pterygium video excision showing how we excise this double pterygium. And corneal traction sutures are taken because you need to rotate the globe for a good dissection. Now, meticulous dissection is done with BP Parker blade. The body of the pterygium is dissected and removed, all tenons removed. Now, superiorly we take a graft. Here, as you can see, we have taken a graft that is small where the limbus is. We apply glue on the two areas where the pterygium has been dissected. We do a horizontal split, and then two thin smaller grafts are pasted over the excised area. And this gives pretty good result using lesser of conjunctiva for a large double pterygium. Now, recurrent pterygium has been covered in quite detail. They are aggressive, they are violent inflammatory reaction with fibroblastic proliferation. They have thickened irregular tissues with adherence to the sclera. And then in addition to it, they may be complicated by cicatricial symblepharon or a restrictive strabismus. So there are certain guidelines for addressing recurrent pterygiums. First, a repeat surgery should not usually be addressed before 6 months of the previous surgery. Meticulous dissection should be done to achieve a smooth ocular surface. We have to give good coverage to the bare sclera this time because you really cannot afford the patient coming from a recurrent pterygium again after that. Autologous serum is preferred because it shows reduced inflammation as compared to fibrin glue and sutures. And in such cases, we have to use antimitotic agents if it required. However, you have to be aware of the risk of scleromalacia. And if a patient has a history of autoimmune disorders, especially rheumatoid arthritis, then it is very, very risky because it causes scleral melt. So this is a 32-year-old male who had a recurrent pterygium after 2 previous surgeries. But then on examination, there were a lot of keloids present on his body. So he is predisposed to scar and fibroblastic proliferation. So here, a large area of pterygium is there. It is very difficult to find a graft in this eye. So extensive dissection is done. All scar tissue is removed. Mitomycin C is applied with a sponge. And then what we had done was we applied sutures to the conjunctiva directly, and we gave some triamcinolone acetate in the subconjunctival area to reduce inflammation post-operatively, and the patient has been doing very well. Now, recurrent, just a minute. Here is a patient where there is recurrent pterygium with a symblepharon. So symblepharon, it is causing visual problems, it is causing motility restriction. So this is best done with a oculoplastic surgeon with you if you are not adept at reconstructing the lid in that part. However, any good anterior segment surgeon will be able to do it. The symblepharon is dissected, the bulbar conjunctiva is tucked back into the fornix and sutured. Then fornix formation is done with bolsters. Here vicryl is being used to form the fornix, and then it is stabilized with a tube, giving a bolster to make the fornix deep. Then the reduced bed of the sclera after suturing it is measured. In this patient, inferior part of the conjunctiva has been used to take a thin conjunctival graft. And then this graft is put over the reduced scleral bed and sutured. We don't want any graft displacement or inversion or retraction, so sutures are used. And we check for motility of the eye. And then 2 weeks post-operatively, good vascularization of the graft is seen, and the patient has good ocular motility also. Little bit fornicial scarring is there, but otherwise the cosmetic result is all right. Now, the most common challenging situation that we get, pterygiums with cataract surgery. Now, what are the challenges? First, IOL calculation becomes problematic because there are errors in keratometry, especially if it is a very big pterygium. So we can either use values of the other eye if we don't have high-end instruments, or we do a corneal topography and take the central part of the corneal keratometry. We have to decide whether we want to do it as 2 procedures, because phacoemulsification in all its steps is not so easy if the visualization is hampered. Corneal section is preferred, clear corneal, because we have to take a graft from the superior part. At all steps of cataract surgery, OVD is used. And if suppose mitomycin C has to be used, then we don't open the anterior chamber till mitomycin C has been applied and copious irrigation has been done to wash it off. Now, the patient factors are also there, whether the patient is willing for 2 procedures or not. There is higher cost factor if it has to go for 2 procedures. There may be very high visual demand, so counseling of the patient becomes very important. Now, whether the patient is keen for premium IOL. Personally, I have not come across this situation because pterygium I have not seen in very high-end patients. They are usually there in low socioeconomic group. But suppose, unfortunately, for some reason it occurs in a patient who can afford a premium IOL and wants a combined surgery. You have to be very careful because IOL calculation may not be so accurate. If the pterygium is large and involving the center, of course, better plan it as a sequential surgery rather than a combined surgery. And look at the cataract surgery itself. How straightforward is the cataract surgery going to be? If there is any factor which is going to complicate the cataract surgery, it is better to go for a sequential surgery, because doing a pterygium and trying to do cataract where the visualization is not proper creates more problems than solving the problem of the patient. So look at the cataract, whether it is a small pupil, non-dilating pupil, hard cataract, pseudo-exfoliation, subluxation, things like that. Now, when it comes to combined cataract, suppose we have to calculate the IOL power, we see that pterygium excision steepens the cornea. So if it is a large pterygium, more than 3.5 mm base, a myopic shift of more than 0.5 is seen in such patients. So when we have to implant the IOL, it is better to undercorrect the IOL by at least 0.5 to 1 diopter to achieve emmetropia. Now suppose a toric IOL is planned. In this case, at least 3 months has to be elapsed between the pterygium surgery and the cataract surgery. There are certain authors who say that you should wait for at least a year also if the cataract can wait, because toricity does not stabilize before that. So we had been doing it at 6 weeks after cataract surgery for such patients who have undergone sequential cataract and pterygium. But after going through the literature, I think I'm personally going to wait for 3 months if the cataract allows it. And when we make side ports, we must avoid the area of the scarred cornea, because hydration of scarred area is not very good, and sometimes the wound integrity is not good. So this is one of my cases where there was a hard brown cataract, and this is a double pterygium, and actually they are recurrent pterygium on both sides. So since I got a good pupillary dilatation and visualization was more or less all right, and it was a hard cataract, I really cannot wait for the patient to plan a sequential surgery. We went for the combined surgery in this case. So pterygium excision was done as usual. Good dissection was done. Tenon was removed from the upper and lower borders of the recurrent pterygium. Now, significant stromal invasion is being seen, so there is a haze. So the crescent is used to dissect it rather than just stripping it away, and a smooth ocular surface is obtained. The nasal recurrent pterygium was very small, so it was just stripped and removed in a small area. Now, before doing any other steps, I want to finish my phacoemulsification. So side ports, as you can see, are made in areas where the scar is not there. Staining is done as usual. Staining is very important in such cases because you do not want to lose viewing of the edge of the rhexis under the scar. So please stain the capsule. Nuclear rotation becomes just as important. And then nucleotomy and removal of cataract is done as usual, keeping the phaco probe and the tip in the area where you can see it. So it has to be as close to the center as possible. Rotate the cataract every time you have to do something rather than going under the area of the cornea where there is a scar. Otherwise, you will land up in problems if you are not seeing what is happening at your tip. So cataract removal was done. There is hardly any cortex there, so minimal cortical aspiration was done. And then IOL was implanted. Foldable IOL in the bag. So far, so good. We do a very good hydration of all the ports because now we have to harvest the graft. And for harvesting the graft, we want a tight eyeball. So harvesting of the graft is done from the superior part. It is a thin conjunctiva, not much tenon adherent to it. The nasal pterygium we directly opposed because that was more like a scar occurring than a recurrence occurring. And the other pterygicide, we did reduction of the scleral bed, made the area smaller, applied the graft and sutured it. Now coming to my favorite topic, pterygium in glaucoma patients. Since I'm a glaucoma specialist, we are very, very touchy about people touching the conjunctiva too much. There can be 2-3 situations. Either it is a glaucoma patient on medication who may need surgery later. There may be a pterygium patient who has undergone glaucoma surgery where there is a bleb present superiorly. Or there is a patient who is post-pterygium surgery who has had a graft taken from the superior part and needs to undergo glaucoma surgery. So 3 situations are there. So the first thing is graft size has to be kept smaller. Now, if the patient has a pre-existing bleb, superior part of the bulbar conjunctiva is not available for us for harvesting a graft. So such patients, you have to look at the other techniques which just now Dr. Vibhuti had described. Now, suppose we are not adept at all those procedures. Then using the conjunctiva of the pterygia itself is an option. So we can use that. And in certain patients where you have to do glaucoma surgery and there is history of the patient being post-pterygium, then it is better to go for other options of glaucoma surgery like a valve surgery or a minimally invasive glaucoma surgery with or without stent, because such patients have a very high risk of failure of the graft of the bleb because of scarring superior part. Now LASIK is becoming very common. Lot of patients, young patients come who have post-LASIK, and pterygium by itself is also a common condition. So there are certain reports where the pterygium is seen in a LASIK patient, and unfortunately it is seen that such pterygiums are aggressive and they invade the LASIK flap quite deeply. So there is stromal invasion present as well. So the surgery per se is as usual. However, when we do dissection of that particular pterygium, we don't strip. It has to be done with a crescent or a BP Parker blade or whatever instrument you have, but don't try and pull and strip the pterygium where there is a LASIK flap, because flap displacement can occur many, many years after a LASIK has been done also. And generally, if the pterygium is done well, there is a good refractive outcome. Thank you very much.
Thank you, Dr. Rasi. With this, we have finished all our presentation. Now I invite questions from the audience. If you have any questions.
Apart from being difficult, is there any harm in taking the inferior conjunctiva, because we can get a lower, more conjunctiva? Is there any harm in using the inferior conjunctiva as a graft as compared to the superior?
Are you talking about surgery in a primary case or a recurrence?
Any case.
Any case. Inferior conjunctiva needs good surgical technique. That is one thing. The other, the availability of bulbar conjunctiva in the inferior part is much less than that in the superior part. Superior part, there is a very large area of graft availability. So it is easier to dissect. You can roll the ball downward, eyeball downward, and a lot of graft harvesting can be done pretty easily. Dissection is in the direction of what the surgeon has to do because he is sitting at the head end. So unless, as far as the limbal stem cell disturbance is concerned, it would be probably the same for superior as well as inferior. But inferiorly, it is difficult to do and there is less fornical conjunctiva available. So you might just end up obliterating the fornix with poor cosmesis also later on.
Yes, in fact, that is one of the conditions which led to this development of this technique, where you are removing the tenons and the pterygium, dissecting it, but you don't have sufficient conjunctiva to cover it. So the permislit is the ideal technique to consider in those cases. Theoretically, you can harvest the conjunctiva from the other eye also, but with permislit, you can use amniotic membrane graft and limbal stem cell.
But whether that would be safe when you are going for a surgery of one eye and you ask the patient that we are harvesting?
Yes, that is why this permislit technique is the ideal technique for such cases. Of course, it will take a lot of time. It will be expensive surgery because you have to use amniotic membrane, you have to use fibrin glue. You are spending a lot of time, maybe 1 hour, more than 1 hour time. So that is there. But for such cases, I think over a period of time, all of us will be shifting to that.
Okay, thank you. Now we have finished this instruction course. Thank you all for your patient hearing.